So wide local excision still remains fundamental to melanoma surgery, and there is a bit of controversy, or at least a bit of a debate about what you need to take. And really, with the in situ disease, you are aiming for a 5mm, less than 1mm, 1cm, 1 to 2mm, 1 to 2cm. And the controversies or differences arise in this upper bracket, so your 2 to 4, your 4mm, and the 3cm is based on the British Association of Dermatology guidelines. Now you have to take into consideration what the scar looks like, so how big it is compared to the lesion that was previously taken away, if you've got photographs, because some people may taken a lot longer scar than you'd expect to take, and then what their peripheral margin is. So you're aiming for a 2mm margin on a excision of a pigmented lesion, but if they've taken 4mm, as Mark Moncrief is an advocate of, you can take that additional 2mm off. Now all of this is based on function, aesthetic, and the reconstruction that's required. Now, the reason for the controversy is because of the different trials that have happened, and in essence, the subgroup analysis that hasn't really always occurred. So Veronesi in 1988 looked at 1 versus 3cm, but they were in ones that have under 2mm. He found no difference. Swedish group, 2 versus 5cm, 0.8 to 2mm, no difference. Bulk, 2 to 4cm, wide local excision in the 1 to 4mm, no difference. But it's the Merriam Thomas paper in 2004 that did the 1 versus 3cm in patients with an over 2mm Breslow thickness and showed increase in local recurrence when they only had a 1cm. But there's no difference in the survival. So Melmart 1 and Melmart 2 have tried to demonstrate, or at least show, that you don't need as big a wide local excisions, and it may well be that the coronavirus outbreak speeds up the rate at which we can do those in trials, because right now, if we can avoid a reconstruction, then we are aiming for a lower or smaller margin. So it may well be that with years to come following coronavirus, then everybody's getting a 1cm margin, but only time will tell. Just as a note, if you get asked about this in either your ST3 or perhaps in your FRCS, you have to stick to your guns. So try not to say 1 to 2cm. Try and say what you'd actually do. And realistically, it's to do with function, it's to do with the reconstruction that's required, and it's to do with the aesthetics. We almost certainly know that 1cm it should be fine. But you can also have that discussion with the patient, and most of these patients are going to continue under observation anyway.